Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. I'm Stephen Newmark, Head of Policy at the Global Healthy Living Foundation.
And I'm Zoe Rothblatt, Director of Community Outreach at GHLF.
Our goal is to help you understand what's happening in the healthcare world to help you make informed decisions to live your best life. So today, in anticipation of World IBD Day, which is happening on Sunday, May 19th, we'll be interviewing a gastroenterologist in Arizona who devotes, unfortunately, far too much of his time to helping his patients navigate the system and make sure that they get on the proper therapies. Dr. Brad Pasternak, who will talk to us a little bit about some of the advocacy that he does on behalf of his patients.
Great, I'm excited to listen.
So let's get into it. All right, Dr. Pasternak, thank you so much for taking your time. It's very much appreciated. We love all advocates here on The Health Advocates, but there's something extra special about doctors who are willing to take time from their busy schedules to travel to Washington, D.C., travel to their state houses to help make lives better for their patients. And it's not just travel, I know. It's hours and hours of educating yourselves on the complexities of step therapy, non-medical switching, and how laws and policies can help patients. So thank you for being with us today, Dr. Pasternak.
Thank you for inviting me. It's always nice to have a platform to try to reach more people about what we're doing.
Yeah, excellent. So let's just start. Tell us a little bit about yourself. How did you get into gastroenterology as a specialty? How did your journey take you to Phoenix, Arizona?
Yeah, that's always a great question. I've always known that I wanted to be a physician ever since I was young. And I've always loved working with kids, just as a camp counselor, as a lifeguard, just growing up my whole life. I've just interacted with children really well. And I got personally diagnosed with ulcerative colitis when I was in college. And so I immediately became fascinated with just autoimmune conditions, inflammatory bowel disease, more immunology and science behind it. And the fact that with all the research going on, we still don't know what causes it. There's no cure for it. So I knew I wanted to do GI just based on my own personal experience. And then, when you think about that, it's either dealing with, no offense, old people and poop problems or kids and poop problems. And I think there's a big difference when you're dealing with that.
Just to be clear, so I'm the old man with the gastro problems, right?
Yeah, or anyone else listening. So I clearly was heading towards the pediatric GI realm. Phoenix was completely unexpected. I did my fellowship training at Cincinnati Children's and was at that time more geared towards research career, translational research. I was working in a really high power lab and had completely protected research time. It was one of those mornings that you wake up and question, what am I doing? I think it was 7 a.m. and I was literally giving a mouse an enema to give it colitis. And
oh, wow.
I just sat there saying, this is not why I went into medicine. I mean, it's not that it's unimportant, just from my personal interest. I love working with people and just sort of had a reevaluation at that time. And I met with my division chief, Bill Balashuri, who's a very well-known name in the pediatric GI world. And he told me about this group that really fit my personality, and they were building a brand new large hospital, and came here in February to visit, to interview, and left just snow, icicles, gray skies to 65 degrees and perfect weather. And I've been here ever since, and they've given me the opportunity to build a robust IBD program and have given me a lot of support. And so, yeah, really, it was just sort of very lucky and managed to find a group that was able to help mentor me and support. So here I am, 15 years.
Wow. That's fantastic. Well, what led you to advocacy specifically?
That actually has been quite recent. I think more within the past 5 years. When I think back to when I started practicing, the medical world was not the way it is today. It's completely changed, and it's been essentially taken over by dealing with payers and policies and prior auths and appeals, and it's a completely different animal. And really, it's come from wanting to do the best for my patients and fight for them. I was fortunate enough to have a patient who worked in healthcare policy for a large company. And then I would call on her whenever there were issues or things that I just felt were wrong. I would call on her asked what her understanding was and asked for some help with certain situations and often griped to her. She ultimately started to involve me in some of her projects. She involved me in, I've written some stuff about step therapy reform here in Arizona. And we had a patient once, I remember, who I had written. It was a teenager who was not growing, who was diagnosed with Crohn's, moderate Crohn's, that I wrote for a biologic, which is standard of care for that particular scenario. And they denied it, stating that the patient had to fail 3 months of steroids before approving a biologic, which in actuality is malpractice. I mean, you're not going to give a child corticosteroids, stunt their growth further, and make them fail for 3 months. I mean, that's just setting them up for a world of adverse effects. So she actually connected me with the CMO of that particular health plan. And then we set up a meeting, and the meeting was 20 minutes. The CMO completely agreed with my concerns and not only overturned the denial, but then incorporated me in their new approval process, a new protocol for approving that particular drug. And we haven't had an issue since. So that was my first experience of like really making a difference locally.
Wow.
And then the stories go on and on. I've got multiple stories of scenarios of denials that I just got more and more involved in advocacy, getting involved with NASPGHAN, which is our pediatric GI foundation. I've been working really closely with Camille Bonta, who's our Washington advocate, and other KOLs in this space because we're all going through it. You know, I've been to Capitol Hill a couple times, and I also started utilizing social media, which, believe it or not, is quite a powerful tool in the advocacy realm. So
yeah, I've heard. Wait, I just want to take a pause for our listeners. The term KOL stands for key opinion leader, and it's often used to, you correct me if I have this sort of on the right path, Dr. Pasternak. KOL sort of refers to doctors who are, I guess, key opinion leaders, right? In the sentence, people who help influence opinions in the field.
Yeah, I would say they're the experts in the field where when you go to conferences or you read papers, like they're the ones that you sort of follow and listen to as far as how they approach different diseases.
Right. So I'm very curious. Can you tell us what it's like when you're traveling to, let's use Washington. What is it like when you're meeting with elected officials or staff and policymakers in Washington or even at the local level as a doctor?
Yeah.
Because we talk a lot about what it's like as patients to meet with elected officials, but what is it like as a doctor?
It's interesting. So, like I said, I've been there twice to Capitol Hill. The first time I actually went representing an organization called the Infusion Access Foundation.
Okay. Yeah, we work with them.
Yeah. So Alicia Barron, who's one of their people, used to work for the Crohn's and Colitis Foundation, and I met her through a couple of mutual contacts. I joined a group of advocates that consisted of patients, providers, infusion center administrators, and then we met with our local representatives. And at that time, we were talking about prior authorization reform. But what's interesting, it's almost like how medicine is structured, where you end up meeting with staffers mostly.
Right, of course.
So, I'm meeting these like immediate post-college graduates or law school graduates and, very young, and they would relay the messages to the policymaker and say they would discuss various points of contention or support with them. And it's a little bit, not sure the right word, but you'd like ultimately as a physician and a person who's I'm a professor, I'm a physician, I run a program. It'd be nice if I had a seat at the table with the policymaker, but because I'm taking time out of my day and my practice to come down there.
Sure.
I think the bottom line is it's a hard road.
Yeah.
And especially on a federal level, once things are going through and there's legislation and you go and speak, it takes a lot to get through to them, to convince them that you have a point. But the process takes a really long time to move the needle, which is frustrating.
Yeah, I'm really glad you said that, only because it's something that I say all the time when I'm with patients, particularly in Washington. It takes a long time. The example I always give is the Civil Rights Act did not start in 1964 when it was initially passed. It takes years. There was actually a Civil Rights Act in 1957. And of course, much pressure. It took a long, long time. And actually, in the realm of history, that probably was considered lightning speed on such an important topic. When it comes to the world of step therapy and what we're talking about, it's much harder. The other thing, just to bounce off what you were saying, is you meet with these staffers, or sometimes you're lucky enough to meet with the actual elected official. And legislating policy, it's not like you can't fit what you want onto a bumper sticker. It's so easy to say lower drug prices, boom, like let's do that, save pro patients. And then you create a legislation and it has all these unintended consequences that weren't thought about. And people who are actually in the field, like you, like patients like me, that are just not thought about when the legislation is being drafted, because it's sometimes about, hey, it fit on a bumper sticker. It sounds great. What's the lower prices, whatever. Let me just to change tacks for a second. We talk all the time on the Health Advocates about the effects of various policies on patients, particularly, some insurance policies. And you were describing some of the steps that are put in the way, and forcing a patient to be on a particular medication for 3 months is absurd. But can you talk about the effects that these policies have on doctors? I mean, how do you even have time to deal with all of this kind of stuff?
Yeah, I think that's a great point. People don't think about necessarily what it does to not even just doctors. I would lump the medical profession as a whole. As I mentioned, over the past 15 years, there's been a total shift in this field. And it went from a lot more autonomy and shared decision-making to literally any drug I write for my patients, with the exception of very few, requires a prior auth, which immediately leads to delay, no matter what. The second that process starts, there's delay, and it's nonsensical. It's not based on evidence. So for me, once that process starts, it's the prior auth, the denial, the appeal, then the repeat denial, then there's a peer-to-peer. And for physicians, for instance, I have peer-to-peers almost on a daily basis where...
Hold on. Can you just explain to our audience what a peer-to-peer is?
It's funny that they call it a peer-to-peer. That's the biggest misnomer.
Huh.
I mean, peer to me implies friend, but no. So a peer-to-peer is a way, so if a medication is denied and there's an appeal, it's a way for the physician or nurse practitioner to have a conversation with one of the medical directors of the insurance company to essentially state their case and argue why it should be approved. And it takes time. And peer-to-peer does not mean that if I'm writing for Remicade for my IBD patient, that the person on the other end is a pediatric gastroenterologist. I could be talking to a geriatric gynecologist. I mean, honestly, it could be the furthest thing from my field, where we have this conversation, and so many times they say, well, you explain why you think this is worthwhile and your reasoning. And well, the literature better than I do. And I'm going to, yeah, that makes sense. I'll approve it. It's a complete time suck that at the end of the day, you could look at the literature. I mean, almost 80% plus of prior auth that go through this process get overturned. If you're someone who knows the literature and the steps, evidence-based medicine, I mean, I don't want to say never, but I would say I'm probably batting greater than 95% in terms of my peer-to-peers getting things approved. So the peer-to-peers are scheduled. They'll say, they'll call you between 1 and 3 on Wednesday, with no regard to your schedule, right? And so I have patients there where I have to say, excuse me, I've been waiting for this call from a medical director. I have to leave the room, excuse myself, take the 5-second call to ultimately tell them, they have that information, tell them what I believe is get the appeal overturned, and then go back to my patient. Sometimes they don't call. They're always calling from some unknown number. And these days, our phones are getting attacked by possible spam. So, you never want to answer these calls. And then beyond that, they require, often before even getting a peer-to-peer, you have to send something called a letter of medical necessity. So you have to put in writing exactly why you want to get this medication or get this study, get this test for your patient. That takes a lot of time.
Right.
And then lastly, staffing. I mean, we have staff now hired that is just dedicated to this process. They're the ones that call, find out, what's on formulary, deal with the prior auth, set up the peer-to-peers. We have to hire people strictly to handle this backlog, to try to remove some of it from the physician. I recently did a survey nationally to ask about just medical providers and the effect that that it's having on them as far as time to approval, administration time. I mean, it's significant how much it affects everyone. And I'm sure is one of the causes of burnout. I mean, without a doubt.
Yeah. Oh my gosh. I mean, I can imagine. I mean, as a patient, I've dealt with insurance companies and I've had my battles and I've had to put things in writing. And I find it to be exhausting to do it for myself, to try and be a doctor where I'm actually meeting. I have other, let's just say other things going on. I can't even imagine. So I'll say it again. Just thank you for all that you do. I know how time consuming, how tough it must be. Let me ask you something more positive. Can you tell us, you've been practicing for 2 decades ish, in the 2 decades range, I think it's fair to say. Can you tell us some of the differences in patient outcomes today versus when you first started practicing?
Yeah, absolutely. I mean, it's night and day. Even from when I was diagnosed with ulcerative colitis, probably when you were diagnosed with Crohn's, at that time, for me, it was steroids, anti-inflammatories, and that was there for a while. Then some of these newer immune modifying drugs came out with, unfortunately, lots of side effects. But now there is just this surge of newer therapies that are more effective, that are safer, and they changed the game. I mean, in the past, the goal was always make the patient feel better, right? Let's improve their symptoms. Let's improve their labs. But now we've gotten to a point where we want to actually heal the colon. I mean, we want to be able to go in and show that everything is completely normal, which we didn't have the opportunity to do with the older drugs. And obviously, our goal is to avoid surgery and avoid steroids. I mean, that's our ultimate goal. I look at, there was an algorithm for patients with acute severe colitis, for instance. They typically these kids will come into the hospital, they'll have terrible disease. And the algorithm was published in like 2017, so not very long ago. And it called for steroids, a trial of Remicade, maybe a second trial of Remicade, and then colon comes out. I mean, it's just sort of, that's the pathway where now we've got newer drugs. We've got medications that work very quickly. And ultimately, we need to already relook at that pathway to say, I mean, I think we've outgrown it. And I think we have the possibility of using newer medications to prevent colectomy. So yeah, the patient outcomes today are significantly better with safer medication.
Yeah, it's a better world. One thing I always say to patients is, excuse my language, it sucks being a patient, it sucks having this condition. But if there's any time on earth to have contracted it, this is where you want to be. Things are getting better each day and newer therapies are coming out. So be positive. So let me ask you, what is one takeaway that you would like to impart on other medical providers, on patients, and on caregivers?
I would say that, as we mentioned, it takes a long time for things to change and there's no quick fix. Things are not changing tomorrow. The more people get involved, the higher the likelihood that change will happen quicker. And that, I guess, from a physician perspective, the goal of a lot of these payers and these processes is to almost wear us out and give up and not necessarily put in the effort, put a patient on a cheaper, less effective medication to not have to deal with going through the process. That is not the answer. I would say, I always say, what if it was your child? Treat every patient as if it's your child and fight as hard as you would for your own child, as you would your patient, and don't give up. From a patient perspective, I mean, I applaud you for writing letters and being involved. A lot of patients don't know what to do and don't really have the guidance as far as the approach. I always tell patients, like, this is going to be a 2-pronged attack. I will fight them on my side, you fight them on your side, and let's see if we can get them to change their decision. So having patients really just take initiative and fight for themselves, contacting their HR department, if it's, a plan through their employer, that's always helpful. Contacting the state insurance commissioner, that always helps. There are people here to help us and try to disallow some of these practices. Social media, I think, is great. You definitely need to be careful because obviously, especially if you represent a company, an employer, an institution, your name gets tied to whoever you work for. And so be careful in regards to that.
Sure.
But at the end of the day, I would say just keep fighting. And even if you're not sure the next step, there are groups like yours. There are advocacy groups that exist all over, and they're always looking for people to help.
Yeah, that's fantastic. I'm just going to add one more from what you said earlier. I like the idea that you said that you got involved because of a patient of yours. who happen to work in health advocacy, but everyone listening to this podcast works in health advocacy, whether they know it or not. So you're an advocate, and that includes talking to your doctors about what you're going through. And you could bring in more folks like Dr. Pasternak to help our causes, and that's fantastic.
And just briefly, because I didn't mention anything of what I've done locally, that actually moves a lot quicker than federally.
Good point.
So I ended up getting contacted by the Arizona Medical Association. They've got an advocacy division, and she reached out to me because she heard about my work in all of this, step therapy, non-medical switching, etc., and asked if I wanted to testify on a local bill involved with something called non-medical switching, which is a payer dictating a switch of a medication to a cheaper medication or a biosimilar, despite the patient doing extremely well on their current therapy. And so I got to testify at the local house, and they actually were very grateful. Not only the medical association, but the legislators were grateful to hear my perspective. And so I don't think they get a lot of physicians that actually testify. I know we're busy, but it can make a big difference.
Yeah, I know that's a really great point. Let me end our discussion here by asking, can we make a promise that we can meet up someday in Washington or perhaps even at the State House in Phoenix to work together to advocate?
Absolutely. I think before the podcast, we were just catching up, and my comment was that we've got so many people working on the same thing, for whether it's rheumatoid arthritis or psoriasis or, whatever, all lupus. All these chronic disease states have their own advocacy groups. And really, I think we all need to work together because the concepts, the fundamental issues are the same. And it's preventing delay, preventing prior authorization, or having some reform there. I'm not preventing it, but having some reform, step therapy. It's all the same fundamental concepts. It's just in each disease state. And it's something where a group like yours that works in multiple disease states, that's where this needs to go.
Yeah, no, absolutely. Well, this has been fantastic. Again, we're so grateful for your time. Thank you, Dr. Pasternak. And we look forward to continuing this dialogue. As I said, perhaps in Washington or in Phoenix. We'll link arms together.
Absolutely. Thank you for having me.
Thank you.
Wow, Stephen, that was a really great interview, and it just reminds me of the power that doctors have to advocate for patients and really be a partner in care.
Yeah, no, absolutely. It is so unfortunate that doctors have to spend so much of their time doing advocacy and fighting for their patients and dealing with this prior authorization and all the other stuff that Dr. Pasternak was talking about. Doctors really should be, practicing medicine, but such is the world we live in, right, Zoe?
Exactly, and we're grateful for doctors like Dr. Pasternak who work hard to fight against these egregious policies.
Absolutely. Well, I'm going to cut you off and say that was my learning, the difficulties that are faced by doctors on their end when fighting for us, and how grateful I am to have great doctors out there like Dr. Pasternak.
Ditto.
All right. Well, we hope that you learned something too. And before we go, we want to encourage everyone to check out all of our podcasts at ghlf.org/listen.
Well, everyone, thanks for listening to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. If you like this episode, give us a rating, write a review on Apple Podcasts, and hit that subscribe button wherever you listen. I'm Zoe Rothblatt.
I'm Stephen Newmark. We'll see you next time.
And happy World IBD Day.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.